Okay. Okay, I think I'll just give it 1 minute and then we can start. Okay, well, welcome everyone. Welcome to the first session of our last day of our CAR-T symposium, Transportation, Air Quality and Health. My name is Haneen Khreis. I'm an associate research scientist at the Texas A&M Transportation Institute and one of the organizers for the symposium. Thank you so much for staying with us until the last day and for making this session. We're going to have 4 really interesting talks. The session's title is The Health Effects of Air Pollution. And you can see the speakers right now on the screen. So we have Ruwan Thilakaratne from the Air and Climate Epidemiology section at the California Office of Environmental Health Hazard Assessment. And Ruwan will start us off. And then we have Mary Fox from Johns Hopkins University. She's also on the CAR-T partners. She's one of the CAR-T partners, the lead on Johns Hopkins University. Then we have Hanna Boogaard from the Health Effects Institute and Michie from the University of Strathclyde. So with no further ado, we'll start with the first presentation for Ruwan, and he'll be talking about air pollution and mental health related emergency room visits in California.
Great, thank you, Haneen. I'm going to share my slides now. Okay. Can you all see that?
Yep.
Oh, I'm on there we go. Okay. All right. Well, thank you everyone for joining. My name is Ruwan Thilakaratne, and I'm an environmental epidemiologist. And today I'll be talking about an epidemiologic study I did while working with the Office of Environmental Health Hazard Assessment, or OEHA, which is within the California Environmental Protection Agency, or Cal EPA. And this work was on air pollution and mental health related emergency department visits in California. And I also want to thank the symposium organizers for the opportunity to speak here today, and thank you all for joining. So first, I just need to make this disclaimer. So the views expressed here are those of the authors and do not necessarily represent those of OEHA or Cal EPA or the state of California. So I want to start by just giving a really brief, I'm sure a lot of you are familiar, but a brief overview of the health effects of air pollution. So air pollution is a complex mixture of gases and particulates, and it's been well established for some time now that inhaling air pollution has impacts on several organ systems. The strongest evidence has been for the cardiovascular and pulmonary systems. And physiologically, it's thought that these effects are mediated through mechanisms involving oxidative stress and autonomic dysregulation. But it's come to light, or there's been growing evidence that air pollution harms other systems as well, including the brain, with most studies focusing on fine particulates, or PM2.5, as the pollutant of interest. And there have been some studies recently showing associations between PM2.5 and acute episodes of mental disorders, usually measured as emergency department visits. And it's believed that these effects may be mediated through the brain's kind of inflammatory response, otherwise known as neuroinflammation, which leads to neurodegeneration and altered neurotransmission. Several other pollutants, though, including carbon monoxide, or CO, and nitrogen dioxide, or NO2, have received relatively little attention in this regard in association with acute episodes of mental disorders. And so we wanted to conduct an epidemiologic study to examine these associations. So this study took place, or we used data from 2005 through 2013, and it was limited to the state of California. And we specifically asked the following questions. So, are short-term changes in these pollutants associated with the daily counts of mental health-related emergency department visits? Is there variation in the association by season, where warm season was defined as May through October and the cool season as November through April? Are certain subpopulations at greater risk of these effects than others? And finally, do area level factors modify these associations? So we use a two-stage time series design to to answer these questions in California, which I will explain now. So in the first stage, we first gathered daily concentrations of CO and NO2 from U.S. Environmental Protection Agency outdoor ground monitors located throughout the state of California, and linked these to counts of mental health-related ED visits within 5 kilometers of the monitors. So on the left here, that map shows the state of California, and the X's denote locations of monitors that were used for the CO half of this analysis, just as an example. So you can see that there's quite a geographic spread. And we then conducted time series analysis to estimate the relative risk of a mental health related ED visit at each of the monitors. Okay, and then subsequently we combined these relative risks using random effects meta-analysis to generate kind of an average or summary effect to kind of combine the statistical power from all of the different monitors and ED visits occurring throughout the state. So to more precisely define our exposure and outcome, so our exposures were same-day to 6-day moving averages of 24-hour mean concentrations of ambient CO and NO2 measured at the monitors. And for our outcomes, we tried to kind of capture a broad array of mental health morbidities. And we used primary diagnosis ICD codes, ICD-9 codes that were associated with the visits to define these outcomes. And so the outcomes listed here, there were, broad, any mental health disorder, and then more specifically bipolar disorder, depression, homicide and inflicted injury. And so that outcome actually, which will be important later, denotes or captures the victims of these, violent encounters. But the idea is to proxy for the perpetrator of the violence that might have been, whose mood or emotional state might have been impacted by the air pollution, as well as schizophrenia, substance abuse, and suicide and self-harm. And as this was an observational study, it was necessary, of course, to adjust for other factors that might explain the associations that we might observe. So we accounted for apparent temperature, which is a combination of temperature and humidity, holidays, day of the week, seasonal and long-term trends in order to capture short-term associations and remove the confounding effects of long-term trends. And we also conducted sensitivity analyses where we included additional pollutants into the model to account for their impacts as well. Okay, so I'm going to go now into our findings. So starting with the first part of that first question, which is about the association between CO and these outcomes. So we found that there was an association, a robust association with homicide inflicted injury visits. We found that for an interquartile range increase in the pollutant, there was a 2.3% increase in risk, which is shown in bold, the bolded row in this table. And this association was robust to the sensitivity analyses involving additional pollutants. So now moving on to NO2, the story is actually much the same. So the outcome that we found associations for was the homicide inflicted injury with a 2.6% increase in risk, so very similar magnitude of association. But of note, this finding was robust to copollutant analyses except for the PM2.5 analysis, and the effect was attenuated when including PM2.5 in the model. And so going to the next question, so we asked about seasonal variation in the effects, and for the CO homicide association, it appeared to be driven by the warm season, seemed to contain most of the effect. And in area level analyses, so these were essentially analyses that tried to use certain area level variables to explain the variability in the monitor specific relative risk. And these analyses were all null. There were none of the variables we examined seemed to significantly explain the variability in the risk across the state. Okay, and so one of our other questions was about subgroups being particularly vulnerable to these effects. And we focused on the homicide-inflicted injury outcome because that's where we saw an association for both pollutants. And so when we broke those effects down into the subgroups, we found that these following groups were at increased risk. Hispanics, as you can see with the highlighted red box on the left, children in the middle, and males on the right. So these groups, compared to the others, seem to have greater associations with homicide-inflicted injury ED visits. And for NO2, the story is again the same, just slightly attenuated compared to the CO effects, but still the Hispanic children and males seemed most vulnerable. So to put these findings into context, the association between air pollution and violence-related visits has been observed in some other studies, though very few. A previous study found really similar associations to ours in terms of magnitude of effect, and their outcome, though, was a little bit different. They looked at counts of assaults. And they did find a warm, kind of a heightened impact in the warm season as well. However, notably, the study was unable to adjust for co-pollutants, and so we were able to show that the effect in our study was robust to adjustment for some of these other pollutants. Another interesting finding is that children were more vulnerable than adults to these impacts. Children are known to be more susceptible to environmental exposures due to their physiology, which we did find here. So this kind of supports that line of reasoning. And there was another study on PM 2.5 and adjustment disorder related ED visits in children. And adjustment disorder does have a kind of violence related or aggressive behavior subtype. And so there may be some parallels to draw there. And finally, of note, we did not really find associations with a lot of these other outcomes that have been seen in other studies, though not consistently, I should say. And this may be attributable it's attributable to probably a bunch of things, but among them, the low range of exposures that we examined as CO and NO2 are for the most part within air quality standards in California. And also population differences. So some of these other studies have been conducted in other countries like China and Italy. And so there may be differences in the vulnerabilities of the populations and their healthcare utilization patterns and et cetera. In terms of the strengths and limitations of the study did have a couple major strengths. So we did have a very large sample size. There were on the order of hundreds of thousands of ED visits that were included in the analyses. And we also were able to adjust for co-pollutants as well. And some of the limitations inherent in this work are that ED visits are not the perfect measure of mental health morbidity. They may systematically overrepresent poorer individuals who use the ER as their source of healthcare, and also severe cases, and may underrepresent cases that did not make it to the emergency room. So, and then also the homicide outcome, as I mentioned, captures the victims and not the perpetrators. Though there's some good reason to believe that the correlations in demographic characteristics between the perpetrator and victim tend to be fairly similar within California. So there, that somewhat supports this, but again, it's not a perfect measure. So what we found was quite interesting because ambient CO seems to be exerting harmful effects below the California air quality standards for that pollutant. And children are particularly vulnerable to those impacts. The biological mechanism is very unclear and probably deserves greater attention in the world of toxicology. And finally, future studies we would advise, continue to adjust for co-pollutants and examine a broader range of CO and NO2, enabling concentration response analysis. Okay, and finally, I just want to acknowledge some of my collaborators here who were critical in making this work come to fruition. And I wanted to note that this work has been published. The work I presented on today was published in Science of the Total Environment. And there is a paywall unless you have access to that journal. So if you don't, please email me. I'm happy to provide my email address, and I can provide you a copy of the article. And then our colleagues on the previous slide also conducted another study on several other pollutants, ozone and PM 2.5, in relation to these outcomes. And their article is open access, so please go and check it out. It was published very recently. And I just have some references here, and just want to say thank you for attending, and I'm happy to take any questions now.
Okay, thank you very much, Ruwan. That was excellent timekeeping. May I suggest that you copy and paste the link for the two papers maybe in the chat box so people can access them or have that reference.
Sure.
We have some time for a couple of questions. So there is one that's also related to that. Are there any other key studies you know of with that look at the similar question, the effects of exposure to PM 2.5 and PM10 and mental or neurodegenerative disorders?
Yeah, so that's a great question. There is I know of a systematic review that we cited that was published in 2018 that looked at a variety of pollutants in relation to mental health related ED visits. And I can also put the link to that in the chat. Yeah, no specific studies come to mind, but the work in this area has been increasing in the last I'd say like 5 years. So it should be fairly straightforward to find something on PubMed. But I'm happy to point. If someone wants me to, I can look into it and see if there are any particular studies that would be of higher quality or something like that.
Yeah, and I think we're gonna briefly touch on that in Hannah's presentation as well. Another question is, can you explain the warranties and findings again? Yeah, I mean, you would think that CO levels would be higher in the winter. Do you guys know what's going on there?
Yeah, that's a great question, and we were thinking the exact same thing when we observed this. So yeah, we did in our data see that CO concentrations were higher in the winter. There biologically, there has been some evidence in animal studies suggests that heat can promote neuroinflammation, the mechanism by which we think that these pollutants are acting. So there's some reason to think that heat may be physiologically modifying the effect and enhancing it. But yeah, it is curious that it only occurs or that it's kind of inverse to the kind of levels of the pollutant seasonally. Yeah, we're not really sure exactly what to make of that, but yeah, we think that there's some biological reason to think that heat might amplify what's going on here.
Okay, well, thank you so much for making the time to present to us. And we'll move on to the next presentation by Mary Fox from Johns Hopkins University.
Great, thank you so much.
Thank you, Ruwan.
Great. Thanks, Haneen. And welcome, everyone. Thank you for joining us. My topic today is related to some of the research that Johns Hopkins has done as part of our CAR-T consortium. And I'm going to be talking about just a piece of it today, the consumer cumulative risk characterization profile. And to get us started, the field of cumulative risk assessment, has been developing over the past 20 years or so. The definition that I'm including here in the middle of the slide is from the Environmental Protection Agency. Combined risks from aggregate exposures to multiple agents or stressors. I've been working in this area since the beginning, since about 20 years ago. And most of our work is still focused on chemical mixtures. So this issue of what are the other stressors is still a challenge for us. But the idea is we're trying to capture this holistic, you may have heard of the exposome, right? It's exposome concept is trying to understand all of the exposures that occur over a lifetime. And the idea is that humans are the great integrator of all of our experiences, good and bad, and across all of the domains of our everyday lives. So our personal and our home environments, our occupational environments, the ambient environments, and our social and community. We have very lofty goals with cumulative risk assessment to try to holistically capture what's going on. But as I say, we've been using the same basic risk assessment approach for about 40 years. And cumulative risk is kind of newer to the party, and we're still figuring it out. And our hope is that this work that we've done as part of CAR-T will help push things forward at least a little bit. So the context of the work that I'm going to describe is a research we did on consumer exposures during refueling. And for many of you probably know the BTEX acronym, but that stands for benzene, toluene, ethylbenzene, and xylene. So these are volatile organics that are part of gasoline mixture. And I hope you'll stay tuned later today. In Session H, you'll hear more about that part of the study, but I'm going to be describing the other parts of it right now. So we had to figure out how we put together a cumulative risk characterization for our participants. And we have there's two things we have to do. We both have to report back to our participants. So we promised that we would do that. But we're also putting forward this case example for the field. And so I'm going to give you a little bit of a sense of how we are putting that together. And the sources of data, of course, include the chemical sampling, which you'll hear more about. I hope you stick around. But we also had our participants complete a survey on some of their personal behaviors, their work environments, their hobbies, and that sort of thing. And we're also linking together information on air toxics from EPA's National Air Toxics Assessment to capture the ambient environmental piece, and community and socioeconomic factors we are building in from the US Census and the American Community Survey. So our assessment now has 5 components, and this table just gives you a little sense of the different metrics that we're working with. So we have very standard chemical risk assessment metrics for non-cancer health effects, that's the hazard index, and cancer risk estimates. From our survey, we have basically just kind of a yes, no. So do we, did the participants report other work or hobby exposures? Our survey included a validated perceived stress scale that has a score from 0 to 16, and we are categorizing that into tertiles of low, medium, and high. And for capturing the community socioeconomic factors, we're using something called the Townsend Index, which is also a score that reflects the relative material affluence and or deprivation of a particular community. And the components of the Townsend Index are things like our unemployment, car or home ownership, and housing overcrowding. So we have kind of a collection of different metrics here. And now we have to think about sort of what are the options for linking these in some kind of integrated characterization. So, it kind of boils down to 3 buckets. There is a qualitative approach where we can, we sort of group the concerns that we see, the high exposures that we see by health effect, and think about how those combination exposures may increase risk in a qualitative, descriptive kind of sense. There's potential to do some semi-quantitative risk work. So even though some of our components are scores, we could develop our own kind of combination index. This type of approach would be good for ranking and prioritization if there are many exposures that we're worried about. And there's also a fully quantitative option that really at this stage can only be applied to chemical mixtures. Some of the other work we're doing is hoping also to kind of push this forward a little bit, so we can also quantitatively, in our risk assessment methods, adjust for important effect modifiers, vulnerable populations, some of the environmental and social justice and equity issues that we are very much concerned about. But given what we have and the relative, we have a relatively small study that we're working with, we're taking a qualitative approach to the integrated characterization. Let me tell you a little bit about our study participants. So we have 34 participants from the greater Baltimore, Washington, DC metro area. Our study, unfortunately, was cut short by the pandemic. So we were hoping to have quite a few more participants, but we have what we have, and so we're moving forward. And just to give you a little bit of a flavor for the community part of this, the 6 places that our participants reside in really cover a broad spectrum of health and socioeconomic factors, from Baltimore City, which has the most challenges, to areas of Virginia, where the health is relatively good and much more affluent. So when we started, we kind of filled things in using our data from our participants. This is the picture we came up with, and we're using a template very similar to this in our reporting out to participants. So in terms of the refueling exposures, just to focus in on benzene, which is the one we were probably most worried about, we measured very, very low exposures. And of course, during refueling, these are very brief, episodic types exposures, and we really would not expect any long-term health effects. When we looked at our ambient air toxics data, we also find relatively low exposures, but these exposures are continuous. And for our participant communities, the National Air Toxics Assessment reports excess cancer risk, and I'll show you in a minute a little bit more specifically what contaminants contribute to that, but benzene and formaldehyde are the top two. We did not have any work or hobby exposures reported. In terms of perceived stress, everyone fell in kind of low to medium. We did not have any high stress scores in our group. And when we look at the community socioeconomic factors, about half of our group falls within what would be considered, again, by the Townsend Index to be a deprived community, and the other half either average or more affluent. And what we know from the research literature is that for those in deprived areas, there are some concerns about cancer risk. So related to mortality and survival. So, we don't have a very strong connection, or, this isn't like a strong signal, but it does kind of lend credence to our idea that, cancer is something that we should be concerned about. And we see this in both in the ambient environment and in the social environment. And just a couple other considerations, right? So we're doing this work as part of a university transportation center. How much are the exposures that we observed in the ambient air toxics data related to transport? And there is somewhat of a fingerprint that shows, at least for these, for the top two, formaldehyde and benzene, they represent a large portion of the cancer risk, and differing proportion of those contaminants coming from on-road sources. So there is some influence here from the transportation side. And is cancer a concern in any of these places? And the answer to that is also yes. As in the United States overall, cancer is the #2 cause of death in all of the communities that our participants are coming from. So how might we show this visually? And I'll bring you back to this kind of basic figure that displays how the various domains of everyday life potentially overlap. And what did we see in our findings? Basically, we see the ambient environment and the community piece lighting up, as you might say, related to concerns about cancer. So how might we go forward with this? Well, certainly, I think it indicates we need to take kind of an integrated policy approach, right? We don't want to we can't just focus on one aspect of exposure. There's at least two things that we would want to look at. We do see there's some connections to transportation, and sort of thinking about systems and health and all policies and those kind of integrated approaches would seem to make sense in terms of the problems that we're observing in our cumulative profile. So this was just one example based on a small study that we did, but there's a bigger picture and more interest in cumulative risk assessment and management going forward. And I think we've heard about that throughout our symposium, particularly from our colleagues at the California Air Resources Board. So some of their community work is really getting at this issue kind of where it matters in communities. One of the things that I heard yesterday was, yes, they're focused on air, and of course I asked this question, right? So, how are they thinking about combination exposures? Or, when you talk to a community, yes, they may be interested in air, but they probably have other concerns as well. And so I was asking our colleagues how they were dealing with these multiple issues. And what came out of that question was the fact that, well, it isn't just air. And they're also being confronted with zoning and land use issues. And they're trying to figure out, so how do they do the partnerships that get to, making change in those areas. And I also hope that they think more about how they can really integrate health and community health metrics into their work. But in any case, where we want to go with cumulative risk assessment, which we have some methods and tools on the assessment side now, we really want to get to the management piece. So how do we really holistically manage things once we understand what the different exposures are doing to our health? How do we influence them? How do we make the changes that really, get the better community health that we're looking for? And we have to think about systems, and that's a natural fit for the transportation sector. And I think there's a lot of emphasis in public health recently has been on, how do we make it easy for people to make the healthy decisions? And again, that's a systems and cross-sectoral kind of discussion that we need to have. So I hope that our example helps move the field forward in terms of cumulative risk, but also into these more impactful types of management approaches. So thanks. And I'll take any questions.
Okay, thank you very much, Mary. And yeah, like you said, I feel that there is actually a move towards cumulative risk assessment in general. And I don't know, my sense is that the transportation sector sometimes lags behind kind of using this framework, and that's part of the work that we did together as well with the Pathways framework, just kind of looked at the holistic range of different exposures. So yeah, that was spot on this topic. I had a question, and we really have time for one question. So I know you said in this particular study you used a qualitative kind of framework, but then on one of the slides there was a percentage of excess cancer risk, with the different chemicals. Where does that come from?
Yeah, so those numbers come from the National Air Toxics Assessment. So yeah, so that data set is, there's lots of interesting features to explore there. And one of the things is that, well, the proportion related to specific chemicals, I calculated myself based on the data they provide. And the on-road percentage also was, I just kind of dug into things a little bit more deeply so I could at least give a sense of kind of the fingerprints of transportation on those cancer risks.
Yeah, which I think is quite important. I mean, I like to see numbers just to get a sense of, what's the magnitude of the risk. Are there numbers like this available for other transportation-related pollutants?
Well,
like in terms of percentage, I mean, we can calculate some of this using certain methods, but are they available in the same document you referred to?
To some extent, yes. So the air toxics, it's quite a complete data set, and there are almost 200 air toxics. Yeah, I was kind of filtering it through the lens of cancer risk, but there's a lot more there that can be explored for sure.
Okay, well, thank you so much.
Great.
Thank you. We're going to move on to the next presentation by Hanna Boogaard from the Health Effects Institute, and she is going to be talking about a massive effort that they recently completed at HEI. So, yes.
Thank you, Haneen. Thank you all. Do you see my slides?
Yes, we do.
Super. Okay. Well, again, thank you so much for this opportunity. Thanks also to the organizers and Haneen. I'm happy to see you. So I'm Hanna Boogaard. I'm principal scientist at the Health Effects Institute in Boston, the US. And just a few words on the Health Effects Institute in case you don't know this organization. So it's a research organization. It provides high quality, policy relevant science. And an important thing here is that HEI does not take policy positions. So I am diving right in. So HEI published a traffic and health review in 2010. We convened a panel to review, basically the full literature on the health effects of traffic-related air pollution up to 2008. This report contained detailed chapters on emissions, on exposure, on toxicology and epidemiology. And at that time, the panel concluded that the evidence was considered sufficient to support a causal relationship between traffic-related air pollution and the exacerbation of asthma in children. They also considered a lot of other outcomes, but basically the evidence was considered either suggestive and or limited for all those other outcomes. Now, a lot has been changed, of course, in the next few years. There's much more research now. That's why HEI has conducted a new review with another expert panel, and we are doing it this time in a systematic way. So many more research has been published indeed. The other thing is that there are so many regulations and really the technology have advanced. Emissions are declining for traffic-related air pollution, and the interest in non-tailpipe emissions and also traffic noise is increasing. So we've done a systematic review. It's currently undergoing peer review, and the publication of this huge report is later this year or early next year. Of course, this is a team effort. We are working with a great expert panel. It's chaired by Francesco Forestiera and Fred Lerman. I'm sure there are many familiar names here. I also want to give a shout out to some HEI staff, especially Alison Patton. I'm not going to spend a lot of time on the methods. We have published a review protocol. It's online for everybody to see. We've used standard methods. We've summarized results narratively as well as quantitatively using meta-analysis techniques. We also include an evaluation of the risk of bias in those individual studies. And at the end of the day, we've reached conclusions about the confidence in the body of evidence, basically using two approaches. We've used the OHAT framework, which is basically based on grade, and we used a narrative evaluation, which takes a more broader look. Just for your information, at the end of the day, these are the descriptors of confidence levels for the presence of an association with traffic-related air pollution. So it's either high if the panel considered that the evidence is really sufficient to that there's a high confidence in the presence of an association, and or either moderate, low, or very low. Some other important features of the traffic review I would like to mention. So this time we evaluated the epidemiologic literature only. And also the focus, and actually we only considered long-term exposure to traffic-related air pollution. So no short-term exposure and health studies. We applied a new exposure framework, and we considered both exposure in a near road environment, so very close to a busy road, as well as neighborhood environments, and so basically the urban environments. And we focused on a selected set of health outcomes chosen a priori. Because, you know, we have to make a selection in the terms of outcomes, health outcomes. There are many health outcomes these days. And the panel selected the health outcomes based on integrated science assessments from the EPA and other authoritative reviews, basically selecting the health outcomes that were either considered causal or likely to be causal, to be related to general air pollution, so not traffic specific, but on general air pollution. So we ended up with those health outcomes listed here. Notably missing are the neurologic effects, the neurologic outcomes. I will say though that at the end, the neurologic effects will be included in the special report. So we have evaluated those outcomes, both neurologic effects in children as well as in adults. But we have not done so in a very transparent way, meaning that it is not a full-blown systematic review. So I'm not going to talk about that further. A few words on the exposure framework, because this is one of the key features what this review, is why this review is different from other reviews, because we focused really on traffic-related air pollution only. Now, of course, the exposure assessment of traffic-related air pollution is challenging. Why is that? First of all, it's a complex mixture, right? It's not only particulate matter and many gases and all that. But the other huge issue is that it's characterized by high spatial and temporal variability. And you know, so far there is no pollutant that is specific for traffic sources, right? It's not that, oh, we have NO here, oh yeah, it's traffic, it's a traffic study, right? The other issue is that traffic-related air pollution impacts at different scales. I already alluded to that, but it's not only the near road environment that is affected by traffic-related air pollution. Of course, it travels, right? So it's also the neighborhood scales and even the urban scales and all that. So we developed 3 strategies to select basically traffic-related studies. And you know, in the protocol and of course in the report, there's a detailed account of that. So diving into some of the numbers and some of the results, of course, I will be short here. So we searched the literature, we searched PubMed as well as some other databases, all the way back from 1980. That was the starting date of the earlier HEI report. So we started from 1980 all the way up to July 2019. Of course, we identified many studies, around 13,000. We applied all our inclusion and exclusion criteria. And at the end, we came up with about 350 studies that were included in the systematic review. Now, about half of them were also used in quantitative analysis, you know, in meta-analyses. About those 350 studies, most of those studied respiratory outcomes in children or birth outcomes, and slightly fewer studies reported on those other outcomes listed here. And another thing to note is that most of the studies we included were published later than 2008. So relatively recent studies, I would say. And I mentioned this again because the HCI 2010 report, the cutoff date was in 2008. So moving on here. Most of the studies were conducted in Europe or North America, some of them in Asia, specifically China. Very few studies included from other regions of the world. What you can see here is that really NO2 was the pollutant that was mostly studied. Following on that elemental carbon and then PM2.5. The other thing is also that about half of the studies also reported on indirect traffic measures. For example, distance to roadways or density measures. And those studies are informative. The panel was not able to combine those studies using meta-analysis techniques because of the varying definitions across those studies. Another note here is that there were very few studies identified on ultrafine particles and also on PM components like the non-tailpipe PM emissions. A last note here, most of the studies included more than one traffic pollutants. So when they met our framework, of course, we extracted all those results. So the next 3 slides, I'm going to show you some meta-analyses and some health data. Of course, you know, there's limited time, so I had to make some decisions here. But this is the first one. So what you see here is the meta-analyses results from NO2, focusing in on all-cause mortality. Basically, what you can see here is that you see the 11 studies that were included at the end of the day. You see the individual estimates from those studies, the relative risks, and you see also the random effects model, the summary estimate, basically. That is the one in bold. And basically, what you see is that they're all positive associations. So an association between NO2 and all-cause mortality from almost all studies, all individual studies, as well as the summary estimate. And what you can also see is that there are quite some heterogeneity here. When you look at the I-square and the prediction interval. Moving on now, this is the next plot. So this is a plot with all the meta-analyses that had been conducted, again for all cause and mortality. So you not only see here the meta-analysis results of NO2, that's the first one, and where I just showed you the first plot from, but also for some other pollutants like elemental carbon and PM2.5. And basically, you know, what you can see here is that across the board, there were positive associations between traffic-related air pollutants and all-cause mortality. And you see also that for NO2, for elemental carbon, and for PM2.5, this association was significant, and it was actually also based on the largest numbers of studies. There are 2 things here to note. First of all, there they are relatively small relative risks. It ranges from 1.01 to 1.06. So we're talking about small relative risk, but that is pretty common in environmental epidemiology. The second point that is important is that those individual pollutants and those associations, they are really considered as indicators of traffic-related air pollution. So you cannot interpret those associations independently from each other. So next slide. This is my last slide in terms of the results. What you see here is the overall confidence assessment in the presence of an association with traffic-related air pollution, taking into account the full body of evidence. So not only the meta-analyses of NO2 or of elemental carbon, but also all the indirect traffic measure studies and all the studies that did not enter into some meta-analyses. And you see that for all the different health outcomes. What you can see also here is the number of studies in brackets that this confidence assessment was based on. And when you look at the bottom of this picture, let's focus on mortality again. What the panel found is that there really was a high level of confidence in the presence of an association with traffic-related air pollution and all-cause mortality, circulatory mortality, and ischemic heart disease, and a moderate to high confidence in the presence of an association with lung cancer. And looking at some other outcomes here, also the panel was pretty confident in the presence of an association with asthma onset, both in children as well as in adults, a moderate to high confidence level again, and also a moderate to high confidence level for acute lower respiratory infections, and for term low birth weight. For some other outcomes, they're listed here, there were lower confidence in the presence of an association. Now, so this is almost my last slide. Some overall conclusions, really, in light of the large number of people exposed to traffic-related air pollution, both in and beyond the near-road environment. Really, the initial findings, they indicate that traffic-related air pollution remains important. It's an important public health concern that deserves continued attention. Some discussion points, I don't know, probably I'm running out of time, right? But let me just say that, of course, there are strengths and weaknesses in our approach. There are some issues, of course, with the exposure assessment, how to assess when it's a traffic-related air pollution study, when not. Some outcome assessment challenges as well, as I can tell you a lot of methodologic challenges that we had to overcome. But I'll stop here. And I want to thank you all.
Okay. Thank you so much, Hanna. Yeah, I mean, I don't have a question, but I have a comment. I'll just say this is a lot of work. This is going to be big when it comes out. If people aren't familiar with the Health Effects Institute report of 2010, you can go and check that out. That's been published. This one is coming out next year. I personally will be on the lookout. But for now, I think if people have questions, please type them in. And if we have time towards the end, we'll return to it. I just want to make sure we could give Craig enough time. But thank you so much for taking the time to share this with us. And again, congratulations on this big achievement.
Thank you.
With that, thank you, Hanna. With that, I'll move to Craig Michie from the University of Strathclyde in Glasgow. And I'll turn it over to you, Craig. Thank you.
Thank you, Haneen, and thank you for the organising committee for giving me this opportunity to come and speak to you all. I feel a little bit of an imposter here today because there are lots of people who have been working in this area for a long number of years and have some really interesting results to present to you. What I'm going to talk about today is something which is much more embryonic in its form, and it's the air quality monitoring that's taking place in Glasgow. It looks like I'm on slide 12 here, so I'm just going to rapidly skim back to the beginning. Now, what I have to do is really thank the GEM association. A GEM, for those of you who don't know it, is an association which is entitled Global Environmental Measurement and Monitoring. And it is an association of which Strathclyde University is a part of. It was founded by the Optical Society of America and the American Geophysical Society. And really what its intention is to bridge the gap between the policymakers, the modelers, and I was going to say reality there, but I don't mean that. I mean, what I mean by that is that it wants to put in place the measurement technology that allows policymakers and the modeling body to have the confidence that the policies that they're putting in place are having some effect and that their models are accurate. Now, GEM has a number of host locations, one in Canada, looking at the Arctic, one in New Zealand. But the two that we're really talking about today are housed in California and in Strathclyde. So the Strathclyde is taking, I guess, is learning from the experiences that Professor Ron Cohen and his team have. They are from the University of California, Berkeley, and they have been monitoring the Bay Area in California for the past 10 years using an array of low-cost or relatively low-cost sensors on an approximately 2-kilometer grid size. And what they've been able to do with that is understand how low cost and relatively imprecise in terms of scientific instrumentation, how these sensors can be used to give meaningful data on air quality. And they use the information that they get from those in conjunction with some inverse modeling approaches that they've been working with to identify key sources of pollution. Now, what we want to do is we want to make use of this approach and replicate this network in the city of Glasgow. So what we're doing is we're working with the schools across the city and also partners in the Glasgow Science Centre, all who come under the umbrella of Glasgow City Council. And so the idea is that we will locate a range of these sensor networks and provide data on a 1 kilometer approximately square grid around Glasgow to give the information that we need to benchmark the policies that are being put into place, give us some public engagement activities with the school, and also through the Science Centre, just promote this kind of measurement capability and the experiences that we have and how we can all play a part in reducing the impact of climate change. Now, this is the map of Glasgow, which is obviously a little bit smaller than the Bay Area, and that's why we're able to locate our sensors in a much more densely populated grid. Each of these nodes that you could see is a school or a city council-owned building. And I've also highlighted something there labeled LEZ that means the Glasgow Low Emission Zone, and I'm going to talk a little bit more about that in just a couple of seconds. So the sensor nodes arrived in Glasgow at the tail end of last year, and each node can measure a range of pollutants that are relevant to the conversation. And unfortunately, like everybody else, we've been delayed a little bit by the pandemic. So we're behind schedule as to where we should be in terms of deploying the instrumentation and gathering the data that we need. And so this is just a screenshot of them in our laboratory being converted so that they can operate on the UK power system as opposed to ones in the US. So I mentioned earlier on that we would talk a little bit about the low emission zone, and why this is interesting is that it complements really what the measurement nodes that we're putting in place will give us, right? So the measurement nodes that we're putting in place will be located at the top of school buildings or up large towers, or far away from the street level as we can possibly get, so we can get an indication of what the background air levels of each of these pollutants is likely to be. Excuse me. Now, the low emission zone in Glasgow took an alternative approach, and they deployed a number of sensors at street level throughout the Glasgow area. Now, what the low emission zone is, it comes from a government strategy that was put in place, I think, in 2016, and it's really to, it was called the Road for a Healthier Future, and one of the objectives of that was to identify where inner cities would benefit from a low emission zone type policy to improve the air quality in those particular areas. And Glasgow was highlighted as being one, because despite the fact that the air quality has been steadily improving over the years, there were and there are some hotspots which are giving cause for concern. So there are two phases to the low emission zone, and the first one of those applies only to local bus services, but beyond that, the low emission zone will apply to all traffic entering the city. Now, if we think about the phase one first of all, the target for that was beginning in 2018 to increase the number of buses, or the percentage of buses that would conform to the highest level of European standards for particulate and other emissions, broadly on a 20% year-on-year increase. So 20% of the buses in 2018, 40% by 2019, and so on up until 2022. So the impact that has had already from the air quality measurements that have been put in place can be seen in this slide here. This is just an illustrative snapshot showing the percentage of NO2, and the target is to keep it below this magic figure here of 100 micrograms per meter cubed. In 2018, you can see the red lines. This shows that there was a significant number of periods where at this measurement node, the target value of 100 micrograms was exceeded. Now, bearing in mind that in 2018, that's only 20% of the bus fleet. No other traffic comes into this category, so other traffic can carry on as it had done previously. Moving on to 2019, and by the end of 2019, the number of buses that had to be, and in fact were, converted to the higher European standards of emissions showed that a significant decrease in the emission rate of certainly NO2. I don't have the data to hand for other pollutants, but I'm sure we can get hold of that. So you can see that clearly this is having an impact. And then going into 2020, you can see what the effect of lockdown would be, because halfway through the year, virtually all traffic stopped, and the air in Glasgow is probably the cleanest it's been for a long time, in common with many other cities around Europe, and I guess more widely as well. So that's where we are. And now the network of sensors that we are going to deploy and are currently working on are looking at the background level, as I mentioned. So they're located very far away from street level, and they're giving us different types of information that we can use to enhance and just give us a greater granularity or richer data to work with for the measurements that the Glasgow City Council have been making. So I show this graph here because that pink dot up in the north is near where I live, which is a village just nearby Loch Lomond, and the other dot, which you might see nearer the city centre, was the first two of these nodes that went in at the tail end of last year. There's nothing that is significant about those measurements. I wouldn't take anything from the fact that they look slightly different in terms of their baseline measurements. These are relatively low cost sensors, and we're in the process of calibrating them so that they can give us real information that we have that we can trust in the longer term. We will locate a high precision calibration node outside of Glasgow where the pink node is shown on that map, and also another high precision calibration node in the city centre. So let me see. So that's where we're at. We're identified, and we've been in good discussions with all of the schools, and we're beginning all of the rollout as we currently speak. The top graph there shows the Glasgow Science Centre, and one of the measurement nodes is going to be located right at the top, so you get an idea of how we're going to attempt to get a measurement of the background location. We will present some of this data at the COP26, working with the Science Centre and also with the schools across the city, so that we can really build up on the citizen science and engagement piece. So there are lots of people in this team, from the GEM network itself, from the University of California, from the City Council. We also have input from the Met Office to help us do the modelling, and the National Physical Laboratory, and other sensor facilities throughout the UK. And with that, I'm finished, and I would be happy to answer any questions.
Okay, thank you so much, Craig. And yeah, we'll give a couple of minutes to see if there are any questions. I think we're kind of doing something similar as well using, would you call the sensor nodes that you're using low-cost sensors? Like what's the average price of a node?
They're low cost in relation to the precision measurement instruments, but these ones here are actually relatively expensive. I think coming in the region of about $8,000 per node, so that's quite expensive. They do have a number, but we are also augmenting that with some other measurement data that's coming from really lower cost sensors, a couple of $100 per node. So we've got a range. We've got some really high end stuff. We've got some mid range or lowish cost sensors, and then some which are almost at the I don't like to say disposable price range, but you know what I mean. But it's really at the very low cost.
Right. Okay. So we've got a couple of questions here. So one question is, can you measure NO2 and NO individually using these nodes?
I believe we can, but what I can do is I can put in the chat a link to the University of California, Berkeley website, and you will be able to find that information there.
Yeah. Okay. And I think one of the strengths of these node systems is that you can also measure CO2. So with the low cost sensors that we're using here in Texas, they don't measure CO2, so they measure criteria air pollutants. But if you look at CO2, then you can also, you're both showing relations with toxic air pollutants, but also with climate change pollutants. So that would be really interesting to look at. And did you guys do a comparison to your more accurate or more regulatory monitoring stations in Glasgow? Do you know how reliable these notes are?
That's what's just going into place just now. So we're going to run that for the next 6 months so that we have that data to give you. And as I did say at the outset, I feel a little bit of an imposter here because we're at the embryonic stage of all of this. But you're right, the comments you're making are completely appropriate and fair.
Yeah, no, yeah, I guess it's something we can all look at, in the near future. Okay, well, that's all I had, and that's all the questions we have. So with this, we will end our session on time. Thank you all so much for making the time to come and present to us and sharing your knowledge, and thank you for all of the attendees. And yeah, we have a 15-minute break before we move into the next breakout sessions, and I hope to see as many of you there as well. Thank you, Craig, Ruwan, Mary, and Hanna. Thank you.
Thank you so much.